Hello, everybody. This is Bob Hecker, and today we're going to go ahead and review diabetic emergencies and altered mental status. This is just a short review for EMRs, EMTs, and paramedics. This will apply as credit for your lecture series. And we won't be too long on this. This is something that you already know. We're just going to go ahead and discuss the body systems again and what can happen with an altered mental status or what can cause that altered mental status. Okay, so let's take a look at these causes here. Some of the causes of an altered mental status can be just as easy as hypoxia. It's one of the most common causes of altered mental status. It's always considering the possibility that the airway is in trouble or the patient has problems breathing. We need to identify and treat life-threatening emergencies. Consider oxygen administration. I want you to be alert to the need for positioning and suctioning if the patient requires it or if mental status worsens on the patient. Determine the baseline mental status of the patient. We use a common acronym called AVPU: alert, verbal, painful, and unresponsive. Again, alert is when they're awake and alert. The patient's answering your questions, no problem. May not be appropriate answers, but at least they're answering and they're engaged in a conversation with you. When we're talking about verbal, this is where the patient is got their eyes closed, they're listening, and when you say something or something loud enough, they open their eyes. That's the verbal portion of this. When we talk about painful, this is where a patient has their eyes closed, they appear to be unconscious, and they are not responding to loud voices, sounds, your commands, etc. So you're going to try something like a trapezius squeeze, the Mr. Spock, I told you so. Or you can go ahead and pinch their skin on the back of their hand, or you can do a sternal rub and see if the patient arouses at this point here. If the patient is that deep comatose, then we're going to put them listed as unresponsive, or the patient is not responding to you at all. So that's our assessment of the mental status for the patient. You want to thoroughly examine the patient that's exhibiting new and unusual behavior. What could be causing this? And we talked about hypoxia for a second here, but there can be other things causing it. And that's the purpose of this lecture right here. We're not going to get into drug overdose, opiates, things like that, which are very common these days. And unfortunately, they're handing out Narcan all the time instead of us addressing the major problem itself, why they're in that problem in the first place. All right, even a slightly altered mental status indicates something serious may be going on with this patient. You do want to perform a secondary assessment on that patient, and our body systems exam and complete history may reveal some information about the suspected cause of altered mental status. Interview the family members and bystanders to obtain the patient's baseline mental status. They may be batty and goofy, and there's nothing wrong with that, but if all of a sudden their change in mentation occurs, then we know it's outside of their normal daily routine. I used to do some nursing home assessments, and I would put in my reports that the patient was alert to person and their own place and time. Nothing out of the ordinary for that patient. The family may be able to provide information that the patient is unable to give to you. Very important, or at least a good friend or somebody who's involved with the care of the patient. The patient's medications may point to relevant medical history. What's going on with these patients? Are they taking diabetic medications? Are they taking heart medication, anti-seizure medications, things like that? Are they taking sedatives? Are they taking stimulants? There are a lot of things that begin causing the altered mental status, even medication errors on the patient's part, where they've taken too much of something or they haven't taken enough of something here. Either way, EMS got involved, and we're the ones that have to figure out what's going on, or at least gather the evidence so that informed medical decisions can be made right here. Look for medical alert bracelets or other health-related items that are at the scene. Check the refrigerator for the pill bottle that has the patient information in it. Most departments have made that expense or at least got donated goods where there's a sticker on the front door for first response and EMS to go to the refrigerator and go get the patient's medical information. Please copy it down or whatever you have to do and then return that. You may have to take it with you to the hospital, hand it to a family member so that they can return it back to that pill bottle that's inside of the refrigerator. All right, children that have an altered mental status may not be able to answer your questions in the same manner that adults do, and therefore their mental status is often difficult to establish. You ever tried asking a 3-year-old about what's going on, what medicines they're taking, stuff like that? No, they're worried about Elsa and movies like Frozen and Mickey Mouse and everything else. A little bit different here. It's been a while since I've had kids, so my youngest is 30, guys. Back then it was Barney the Purple Dinosaur. All right, that's how old it is. All right, ask the parents or the caregivers, are they acting differently than normal? We need to put that in our notes and track down what's going on with the patient. So the big topic that we're dealing with altered mental status, of course, is going to be diabetes. And we're going to discuss these in just a moment. There are 2 different types of diabetics. You got your type 1 and your type 2. And we'll differentiate what is different between these guys. All right. Take a look at glucose and the digestive system. So insulin's needed to help the cells take in the glucose. What produces the insulin? The pancreas does. Okay, the islets of Langerhans. That may be something that you remember way back in EMT or EMR school. These are specialized cells that are inside of the pancreas, and they produce the insulin. Insulin gets squirted into the bloodstream, and then it attaches to the glucose cell, and it brings it attaches itself to the glucose. And when it comes to the cell wall, it's actually the key to open the lock, to open up the door on that cell wall and let the glucose in. That molecule is very large. Now, glucose is a form of sugar. There's fructose, glucose, glucose. There's a bunch of different variations of sugar molecules, but this is the body's basic source of energy. The body cells required to remain alive and create energy. So again, it needs insulin to bring it through that cell membrane. Very important here. Now, when we have an increased amount of sugar intake, the body senses that, and then it will dump more insulin into the system. Now, for a normal person without any digestive issues, without any blood sugar regulatory issues, their blood sugar remains between 80 and 120, which is the American Medical Association definition of normal blood sugar. So if it's 81 or it's 121, they're going to call you pre-diabetic. And they're going to want you to change your diet, bring those numbers back down below 80 to 120. You know, if it's below 80, we know we got a problem, guys. That's why we're there in the first place. And rarely have I seen an emergency where 120 is high blood sugar. We'll discuss that in a little while. So things are a little bit different. So the different types of diabetes we talked about, there were 2 types, type 1 and type 2. The type 1 diabetic, that's where the pancreatic cells are not functioning properly here. Insulin is not secreted normally into the circulatory system, and there's not enough insulin to transfer the amount of glucose that's in the body into the cells. So synthetic insulin, typically prescribed to patients, will supplement the inadequate natural insulin. Now, some patients will take NPH, they'll take Humulin, Humalog. You've seen people with these special injector pens now where they're going to have little tiny needles and inject into their abdominal area, such as Jardiance and things like that. Those type of medications are needed to supplement what the body is not producing enough of. Now, type 2 diabetics, these patients' body cells fail to utilize the insulin properly here. The pancreas is secreting enough insulin, but the body is unable to use it to move the glucose into the cells. So this condition is usually controlled through diet or oral anti-diabetic medications like metformin and things like that. So you might have also heard that you have adult onset diabetes. This is what they're talking about. As we get older and we are not controlling our diets, body systems are starting to fail, lack of exercise. These are the type of things that are causing the adult onset of diabetes. Type 1 is usually another word called juvenile diabetes, where these patients are born with these issues to start off with. And sometimes they can be very critical. The type 1 diabetics may end up with an insulin pump, where this is a device that attaches to their body and will pump insulin into the system on a regular basis. They even monitor themselves on different times of the day what the highs and the lows are, and it adjusts the amount of insulin that it pumps into the system. You may find patients with something the size of a cigarette lighter or something like that that's actually glued to their skin. It may be on the back of the arm or something where it's not in a way, and those last 30 days, and then they peel those off, and then they'll put another one on at a different location. That's an example of some of those insulin pumps. Okay, let's talk about hyperglycemics. If you've got this reading on your glucometer and it's calibrated, your patient is probably unconscious here. Hyperglycemia is high blood sugar. The causes of it is a decrease in insulin. It may be due to the body's inability to produce the amount of insulin, and it may exist because insulin injections given are not of sufficient quantity. Hyperglycemia causes can be caused by stress and increasing dietary intake. The signs of hyperglycemia, this is something that develops over days or weeks. There is chronic thirst and hunger. You have increased urination and nausea. So you have to think about this. There's a saying in the EMS community called the 3 Ps of diabetes. You got polyphagia, which means you're always hungry. You got polyuria, which means you have increased amount of urine. And polydipsia, which means increased thirst. So it's a very vicious cycle here. The patient feels weak, they eat. They're peeing all the time, and they're drinking all the time, and it's not correcting itself. That's what's going on here. So what happens is the patient is now in a state of profound dehydration, and then you have excess waste products released into the system, and this is known as diabetic ketoacidosis, or DKA. If you ever hear the term used by a paramedic or an RN or something like that, the patient's in DKA. They've got a very high blood sugar. Their sugar is circulating around inside of the bloodstream, and you have to think about that sugar molecule. I told you it was very large. Well, I'll tell you what it's like. It's like little shards of glass. And those little shards of glass are going through the blood vessels, and they're making tiny micro tears inside the blood vessel walls, inside the capillaries. And that is usually the damage that is caused by high blood sugar. So the body's response to these little tears is, let's go ahead and fix it. Next thing you know, a clot is going to be forming. That's why diabetics have severe heart disease. And diabetes and heart disease is what's going to kill the patient. It's going to be a result of that. Now, we talked about DKA, or diabetic ketoacidosis. So again, it is a profound altered mental status. The patient is in shock, which is caused by the dehydration. They have rapid breathing, almost a Kussmaul respiration, and they're unconscious. And an acetone odor on the breath, or a fruity smelling odor. This is an aromatic hydrocarbon. So again, diabetic ketoacidosis. Ketones is what the acetone smell is, and that is where that is coming from. So when we're assessing our patient, let's do a secondary assessment on them, get all their vital signs, find out if the patient has a history of diabetes. Again, look for a medical identification device such as a bracelet, etc. Check the blood sugar level right here. Remember, I told you that range was 80 to 120, which appears to be normal. But if we have a sugar less than 60 milligrams per deciliter in a symptomatic diabetic, then we're hypoglycemic. If we're less than 50, we probably have a significant altered mental status with this patient. I have seen patients still talking to me with it in the 30s and upper 20s, but not for long. Now, patients with blood sugar greater than 140 milligrams per deciliter is considered hyperglycemic. And when you look at patients that have blood sugars greater than 300 for a prolonged amount of time, those are the ones that are going to have signs of dehydration and more serious symptoms. Many glucometer readings may display the words high, H-I-G-H, or H-I, which means they can't measure it. You only have slightly 3 digits, and it's going to go to 299. If it's above that, it's going to be labeled as high. Again, if it's high, I'm saying 300. Some manufacturers say above 500 on this one. If it's low, that means that it is very low and usually less than 15 milligrams per deciliter. I have never seen a negative number on these meters, even if they weren't calibrated. So, just to remind everyone, we have fairly new glucometers on all of our trucks with our med bags. We have a fresh supply of test strips. Again, when you are checking your equipment once a week, you should go ahead and bring your glucometer to station 131. Go to the district chief's office. They have some control solution upstairs in their office. The control solution is a certain amount of sugar will show up. You put it on a test strip, and you will test your meter against that control solution, and it should be the same reading that's on the side of the bottle. I am not sure what that number is. It might be 80, it might be 90, it might be 100, I'm not sure. And whenever I buy new test strips, I get a new control solution. That way, we don't have old solution. If you suspect your glucometer is giving you problems, that's when you really need to do it. I had mentioned Thursdays we check our medical bags. We do need to check that our glucometers are working. Each one of them takes 2 batteries in the back. Usually by the time we have to change batteries, it's time for us to change meters anyway. And we do have a few spare meters in the event something's wrong with yours. All right. So that's what you're going to do for checking your equipment out. Keep it clean at all times. When you're done with it, I would wipe it down with an alcohol prep. Even though you're wearing gloves, you're touching it with gloves, but you may be picking it up without gloves. So that's why you need to keep your equipment decontaminated. Okay. Dealing with patient care, we do carry oral glucose or oral glucose. Again, criteria for administration: the patient has a history of diabetes. They do have an altered mental status, but they are awake enough to swallow. So, patient squeezes the glucose from the tube directly into their mouth. That's fine. Or you can put it on a tongue depressor and you can place it inside their mouth between the cheek and the gum. And there's a reason for that. In case the patient becomes unconscious, you can remove that tongue depressor with the majority of the goop that was in there so that their airway can remain clear enough in case that you would have to bag this patient if they were to go into respiratory arrest. Or you would have to suction the patient. Don't forget to bring your suction machine in when you're dealing with an altered mental patient. All right. Also, I'm sorry, that's a repeat of that same slide, but that's okay. When it comes to dealing with administering oral glucose, what else could work? Think about it. What does a patient have in the household that would work? They could eat a piece of candy. They can drink a sugary cola or orange juice or something like that. Look, Diet Cokes don't work here, folks. I'm sorry. Unsweet tea doesn't work either. But bottom line, if we can get their blood sugar to raise enough for their altered mental status to become to be back within guidelines, that's what we're looking for. The other thing we have to watch is patients that we may have cured with the sugar are awake and alert enough now that they don't want to go to the hospital and that they can control things themselves. Again, you should encourage the patient to get checked out. If you haven't canceled EMS by this time, let them come in and continue their assessment. They may want to take the patient into the hospital. Remember, the sugar that we cured them with is a quick fix, and it's not going to last long. And I explain that to patients and family members that this may only last 15 minutes. Think about using an EpiPen on a patient who's in profound anaphylaxis. Hey, they're ready to roll, and they don't need your help. But in 15 minutes, they're going to go right back to the problem that they had. If they're adamant and do not want to go to get checked out, encourage them and the family members to eat a significant amount of calories to sustain them. Otherwise, you're going to be back in an hour. So, if there aren't any questions, well, how are you going to ask me a question? I'm on a video here, right? You can email me, Robert_Hecker at stfd13.org or training at stfd13.org, or you can text me. I will be happy to answer any questions that you may have on this quick review of altered mental status. Have a great day, stay out of trouble, and be out there to take care of your patients. Thanks.